Thank you for taking time from your busy day to watch this special presentation from the El Paso County Medical Society. I'm Dr. Joel Hendricks, President of the El Paso County Medical Society, and it is my hope that you will find our program of great interest, educational, and informative about the medical care provided by some of our best physicians in our country, right here in the Borderland. From all of us at the El Paso County Medical Society, please enjoy tonight's program.
Urinary tract infections, they're a lot of fun, right? We are adults, but if your child has a urinary tract infection, how can you tell if they're not of the age where they can actually tell you what's happening? Are there body cues that they're telling you about? Are there body cues that you can watch for? What are some of the other conditions that are associated with urinary tract infections and just in general the urinary tract? We're here to talk about pediatric urology today, and it's important for parents to understand their child's anatomy. Yes, we're going to talk about genitalia tonight, and I know that sometimes it's cringeworthy to do that, but when your children are growing up, they are often embarrassed, as are the parents, to talk about these things. So we'd like to bring a lot of that to the forefront tonight so that you have an ability to talk to your kids or your grandkids or whoever might be growing up around you, and also signs for you to watch out for if there are issues. What is normal and what is not normal as far as function and pain in the genitals. This evening's program is underwritten by the El Paso Children's Hospital, and a big thank you to the El Paso County Medical Society for bringing this program to you. I'm Catherine Berg, and this is the El Paso Physician. Thanks again for joining us. I'm Catherine Berg with the El Paso Physician, and we are talking about pediatric urology tonight. And we were just discussing that there are so many things in our culture, in America and in Mexico, that are kind of taboo to talk about. And I think that today it's super important. And we're going to start with babies, brand new babies. We're going to start maybe even with some conditions that we might be able to see prior to a baby being born, and this is all in the genitalia area. So I would like to introduce Dr. I didn't even ask you how to pronounce your first name. Sorry, we're just sitting here caught up in conversation this entire time. You're just Dr. Alam, but pronounce your first name.
Shumyle.
Shumyle, Dr. Shumyle Alam, and he is a pediatric urologist at El Paso Children's Hospital. And we have Belen Terrazas, who is a nurse practitioner at El Paso Children's Hospital. And thank you so much for being here. What I'd like to do, Dr. Alam, if you can sort of discuss what your background is, what is a pediatric oncologist, a pediatric urologist, just so that people at home can kind of understand what it is that your specialty is. And Belen, I'm going to do the same thing with you in a few moments as well. Dr. Alam?
So pediatric urology is basically, as you said, a field of medicine looking at the genitals, the urinary tract. That includes the kidneys, the bladder, the ureters, as well as the urethra, and in boys, testicles, and girls, ovaries, as well as the uterus. And pediatric urology is both a surgical and a medical specialty. Mm-hmm. So it is unique amongst surgical specialties in that probably half of pediatric urology is in fact medical management of the kidney and the urinary tract. The other half, pediatric urology, is surgical, and we can talk about some of those conditions as we get further on today. But the main conditions that we take care of are regarding the genitals and the urinary tract.
Okay. Thank you very much. I know that you've been working with Belen here for a while, and I know, and Belen, we want to talk about nurse practitioners in this realm and doctors in this realm, but you do an awful lot when it comes to urinary issues with children in the nurse practitioner role. What is it that your role is, and how does it complement the doctor's role in this situation?
Well, the good thing about my role is that I'm in the clinic every day, Monday through Friday, because I don't go to the operating room. That's not my area. Mm-hmm. So if there's any problems, there's any referrals, anybody needs to be seen immediately or right away, I'm there.
So you're one of the first lines of defense when people start coming in.
If there's questions, they could text me, they could call me, whatever is helpful. If, they have recurrent UTIs and they've already had 6 UTIs and they're like, I need this child to be seen, I need help. And we need to get to the bottom of it. It's like, we need to investigate, why are we having so many UTIs? And are they true UTIs? Right. So I feel like that's my way of helping the pediatric urology community by being more available.
And I'd like to speak this evening about parents and the questions that they ask. So I'm gonna direct a lot of those your way. I'm gonna ask you in a little while, what are some of the most common questions that parents ask you, but then also seeing past that cloud, right? They're gonna ask a question, but you really know that they mean A, B, C, and D, because certain topics, again, it's not that it's taboo, but sometimes they don't know how to ask an uncomfortable question or an embarrassing question that they may consider an embarrassing question. So I'd like to turn it over to Dr. Alam for a second and talk about some of the most common issues that you see. And then we'll transfer it also to Belen and see what some of those questions are that the parents are asking about. So in your day-to-day life, what are some of the most common issues that you see?
The most common pediatric urology referrals in males are usually about the foreskin, questions about the foreskin. And that's the first thing that you see with your baby boy is the foreskin. And parents have to make a decision if they want the child circumcised or if they want to wait. And there are no real right answers in terms of that. But as time goes on, sometimes uncircumcised children may have some issues, or more importantly, there may be some concerns when they're seen by maybe physicians who are not used to children who are uncircumcised. And so we get a lot of
Oh, interesting.
yeah,
Okay.
we get a lot of evaluation for circumcision-related problems that aren't always problems.
If you were to throw, and it doesn't have to be exact, but if you were going to throw a percentage out there of how many males are circumcised versus not circumcised, is that a high percentage? You know, what in general, 50-50, 60-40, 90-10?
It really varies depending on where you are in the United States. I mean, in Europe, it's the majority are not circumcised. In the United States, it falls really under cultural lines.
Okay.
So in the East Coast and some of the big cities, probably greater than 50% of the males are circumcised.
Okay.
When you get closer to more Hispanic communities, the rate of circumcision tends to go down. And then there are some outliers. For example, in inner cities where there are a lot of patients who are on public insurance, sometimes circumcisions aren't paid for.
Oh,
And
good
by
point.
default, even though the parents may want their child circumcised, they are not circumcised. And so it's very difficult to come up with a number because not all children have problems who are either circumcised or uncircumcised, but it tends to follow those lines.
And in general, and Belen, I'm going to ask you this question. So I'm trying to think, because usually prior to a birth, the parents will know, am I going to have my young boy circumcised or not? What are some of the questions that parents ask you about, whether it's a cleanliness issue, just medical issues? I understand the cultural issues around circumcision, but just medical cleanliness, et cetera. What are some of the questions that you receive from parents on should I not, or is that even an issue?
Yes, no, they do ask a lot. And they want to know, like, is it medically necessary? Is it going to cause UTIs? Because they hear that a lot. I want them circumcised because it's a hygiene issue and because it's going to prevent UTIs. And it's not true.
Okay. So on that note, let's carry that a little further. So, and I'm thinking again, diapers are an immediate thing. And let's say it's a brand new parent, someone who hasn't changed diapers before, and now they have a young boy who's not circumcised. And let's talk about loose stools, right? And so it's just a mess. How are questions presented to you of how to clean properly, taking the foreskin back or not with cleaning when your baby is like tiny, 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 and then going forward too. And we can carry that through to when they're starting to potty train and when the young men are starting to, when the babies, when the toddlers are starting to clean themselves, et cetera. Explain some of that thought and theory as you're talking to parents.
So the foreskin does not need to be retracted. It does not need to be forcefully retracted at all. Smegma is a white, cheesy-like substance that forms naturally, and that forms a barrier and it helps the foreskin separate by itself on its own.
Okay.
So forcefully, you don't want the skin to tear because if the foreskin tears, then it bleeds and then they're hurting and that skin can scar and cause further problems.
You know, I was doing research on this topic today, and there was a story specifically about that, which is why I wanted to bring it up. And again, the reason I'm saying this too is brand new parents have never dealt with it one way or the other. The father in the story that I was reading was circumcised, so it was kind of new to them. Mom didn't want the circumcision
Right.
for the young man, and so it did talk about a major infection that occurred because dad kept, again, forcefully moving things around. So
Right.
going through the life in general, when you're looking at young boys that are circumcised, is there any difference in cleaning, diaper cleaning? And the way I
No.
understand it, there really isn't, but I want
No.
everybody to hear it
Yeah.
from a medical professional.
There is no difference.
Okay.
But you do have to consider one thing, that if the dad is circumcised and the little boy is not, as he's growing up and he's taking a shower with dad, or dad's, how come you look like this
Oh, good
and I
point.
look
Right.
like that?
Right.
So you have to take those kind of things into consideration.
Right. And that goes back to the opening of the statement, right? It's like, when is it okay to speak about genitals? And it's like, in my opinion, and you guys tell me, from the get-go. I mean,
Yes.
never make it an issue. It's like, this is why, and this is what it is. And Dr. Alam, maybe describe some of the situations you've been in and questions that you've been asked by parents.
Well, regarding circumcisions and foreskin, it's usually those questions. There's a great quote from one of our old pediatric textbooks, and it starts off by saying the only person who should manipulate the foreskin is its owner.
Ah,
And so we
Okay.
have a tendency to pull the skin back, to do a bunch of different things, and it just kind of creates problems. But in addition, the diapers have gotten so good at absorbing fluid these days that sometimes children may sit in diapers longer than they would have in cloth diapers.
right.
Maybe the children get a little bit dehydrated, and sometimes that urine gets a little bit strong, and that can irritate the skin.
Right.
And then all of a sudden, the foreskin is blamed as a problem. I like to explain it this way to the families. No matter if you believe in a God or Mother Nature or whatever you believe in, what life force could create something where when you're born, it has to be removed? It doesn't really make sense. And I don't get involved in terms of religious discussions or otherwise. We tend to do what the families really want us to do. But when they have questions, we try and make them understand that there are really no good right or wrong answers.
Right. And that, I love that you're really making that a point this evening as well. So other than that, what are some other pediatric urology type issues? We can, I wouldn't mind going into some of the congenital stuff immediately, because I think sometimes we run out of time, and I think
Right.
that's so important as pediatric urologists. What are some of the congenital issues that you see happening that you have to deal with?
So it's an important fact to note that with prenatal screening, with ultrasounds, the most commonly identified problem prenatally is in fact urologic, whether it has to do with
The most
dilation.
common is?
The most common.
Interesting. Okay.
Whether it has to do with dilation of the kidney, problems with the position of the kidney, problems with the amount of fluid around the baby as it relates to the kidney, bladder, or urethra, or genital anomalies. And so we tend to detect a lot of pediatric urology conditions prenatally. So many patients, when they're pregnant and go see their maternal fetal medicine physician, will have some kind of urologic anomaly. And we counsel those patients prenatally
Good.
in order to help
Okay.
them define a birth center and a birth plan. It should also be noted that the majority of those conditions don't necessarily require surgery,
Okay.
but early detection helps the families plan and demystifies that sort of shock that you would get after delivery that something's wrong with my child. Now, when it comes to the penis, one of the more common conditions that we see are abnormalities of the foreskin that are also associated with problems in the urethra, meaning that the urethra doesn't make it all the way to the tip. That's called hypospadias.
Okay.
And that happens about 1 in 450 live births.
Oh, okay.
When I was in medical school, it was 1 in 1,400. And yes,
Okay.
it hasn't increased with time.
why? That's interesting.
We don't really know. There are some theories, and we don't need to get into them, but
Right.
it is more common than it used to be.
So how that has to be surgery, correct? In this point, so you have to somehow extend.
We do.
Okay.
Sometimes children can live with their hypospadias, and part of the reason why it may be more common is that we are more interested in looking for it. I've seen some statistics that it's actually 1 in 150
Okay.
when you include abnormalities of the foreskin.
And how dangerous is it? Is it something that you can go on for years and not realize? Like you said, you're now trained to look for it. In the past, has that been something that you will eventually find anyway, or are there just problems from the get-go that go undiagnosed?
Well, usually the conversation is around circumcision. So
Okay.
the pediatrician will notice that the foreskin is incomplete, or abnormal, and the urethra isn't at the tip, and that usually stops the circumcision process. So the most important thing is when a child has a hypospadias, that they don't have a circumcision, because we use some of that skin to reconstruct the penis.
Okay.
Now, unfortunately, with hypospadias, the more severe the hypospadias, mean the further it is away from the tip, the more it's associated with curvature of the penis.
Okay.
And curvature of the penis can cause some problems in the future, both with erections as well as urination, and those patients typically would benefit from surgery.
Okay. And when you say benefit from surgery, if you don't mind, and I love just doing ideas of case studies. Again, the story that I read today, because I think people have a way of wrapping their head and arms and mind around a case study. So when you say surgery, what exactly physiologically are you doing in the operating room when you're trying to correct this condition?
So the simple explanation is at the end of the operation, the child will look like he is circumcised.
Okay.
But that's kind of a simplistic view. What we do is we straighten the penis, so we take away the curvature.
And how do you do that? Again, I'm just thinking physiological. So is it a muscle situation? Is it, so you've got the urethra that's the ureter, sorry.
Urethra.
The urethra. See, we
Yeah.
were talking about this before the show. So physiologically describe what it is that you're doing in surgery.
So the penis is curved.
Right.
The urethra may be below where it should be.
Correct.
So the first thing we do is we take an incision, take the skin down, and straighten the penis.
Okay.
Which sometimes actually drops the urethra.
That makes sense, right?
And
Okay.
then we reconstruct the urethra by tubularizing it all the way to the tip.
And what material do you use?
We usually use very, very fine suture,
Okay.
probably the thickness of your hair.
Okay.
And we use operating microscopes and operating magnification to do so. And then you can't just make a tube. You actually have to put some tissue with some good blood supply over it. And then you put a small stent in to what's called divert the urine. So the urine drips out of the stent. And that stays in anywhere from 5 to 7, sometimes 10 days while the urethra heals.
Okay, that's
And then
quick.
it's taken out in the office, yeah. It's a pretty straightforward procedure. Again, the frequency of hypospadias really is leaning towards the more minor hypospadias. But my actual interest is reoperative hypospadias because sometimes patients have surgeries that don't go to plan. And I do a lot of secondary, tertiary, quaternary surgeries for that condition.
So I'm thinking too, just in my head, right? You're doing a surgery, you're reconstructing, and this is a little tiny person. And as this little tiny person grows to be a little bit of a bigger person, is what you're reconstructing is again, it's live tissue. So I'm assuming what I'm hearing, if I'm hearing it correctly, that the live tissue just grows with the child. Is that correct? Has there been any issues regarding that?
There's been a lot of issues.
Okay.
So if the surgery is done in a certain fashion, the patients can develop scar tissue. And as they get older, the curvature doesn't go away.
Ah, yeah.
And a 15-year-old boy with the penis that is curved is not necessarily a very happy 15-year-old boy. And repairing that 15-year-old boy is a pretty big deal. And so the surgery has to be done very carefully. It does require quite a bit of training to know how to do it. And it has to be done in such a fashion that it does grow with the child.
So this is a good transition to talk to Belen now, because Belen was talking about how important she finds it, and I find it too, that conversations between parent and child start from day one. And so this child has had, I'm just going to use this case study that we're talking about now. And so 3, 4, 5 years old, when children start to become aware of their bodies, and they may not know that their penis is curved and other people don't have curved penises. So maybe talk about, not maybe, but please do discuss the communication that should be occurring between mother and child, because there's a certain point too when the child probably not going to want to tell mom and dad when he turns 7, 8, or 9, because you're talking about a 15-year-old and having to do surgery at 15. And could this be helped when he's 6, 7, 8, 9 versus getting to really the hormonal ages? And take that any way that you'd like to discuss that.
Well, I think that it becomes more notable when they're starting to potty train,
Okay.
because now they're wearing underwear and there's not like hiding in the diaper. And so if they're urinating and the stream is going up or the stream is going all over the place, the mom wants to know, why is my child making such a mess?
Right.
Right.
Simply said, but absolutely. Yeah.
So, that's usually when I think
Okay.
the conversation has to be made, It's like, well, what's going on? Why are you making such a mess?
Right.
Instead of it just being always boys will be boys.
Yes.
So at that point is when you start to notice with girls and with boys
Okay.
more urinary problems
Okay.
because
And
now
is
they're
there an
potty
ideal
trained.
age before getting to the age of 15? Is there an ideal age that this should be corrected prior to really becoming a man, so to speak?
For hypospadias, we
Yes,
usually
for
require
hypospadia specifically.
6 months of
Yeah.
age.
Okay, but I'm thinking you had the surgery and then they have to have a resurgery between 15. I'm thinking to myself, there's that 14-year gap
Oh.
of, you know what I'm saying? Of when, okay, I really do need to correct this now before I get to a certain point where it's really uncomfortable and something more dramatic needs to be done.
Well, one of the fundamental tenets of surgery is to follow your patients
Yeah, okay.
and to make sure that they do well. And Belen, she sometimes sells herself short. She's that point person. So the parents will call her. I may see the patient when they're 18 months of age and say, things are great. Why don't you call me if there are problems with toilet training? And Belen's the first point of contact. And they call her and they say, oh, everything's a mess. He can't aim. Maybe he has 2 streams, and that could be what's called a fistula,
Right.
where it opened up a little bit.
Right.
And that's how we detect it.
Okay.
And so, yeah, the 15-year-old is a bit of an extreme. I've operated on 20-year-olds. These are extreme circumstances, and the way they got to that point has to do a little bit with the care they had, the people they saw, and the plans that were communicated to the family. But
Okay.
if there's a complication from a hypospadia surgery, we like to fix that within 6 to 12 months of the initial surgery.
Yeah, why not? Exactly. So we've talked a lot about young men. Let's talk about the girls. What are some of the more common issues with girls in the area of urology?
UTIs
Okay.
is number one, I think.
Okay.
And bedwetting.
And young, I mean, we're talking young ones.
Some are young, yes.
Okay.
We do get some that are babies too.
And what are the causes? Is that cleanliness? In my head, I'm trying to think, is
Right.
there are some girlfriends of mine that I feel like they always have a UTI, like constantly, and those that never have them or rarely do. So what are some of the common issues and reasons why
Well,
women have UTIs?
it's not wiping.
Okay.
It's not that.
Mm-hmm.
'Cause,
Yeah, because that's the common
that's
thought. It's
the
like, well,
common
keep yourself
thought.
clean, you're not getting UTI.
Exactly,
It's like
yeah.
it's not about that.
But more
So-
common is constipation.
Okay.
Starting even with babies.
So physiologically, I know we have a model here. I don't know if that's going to show what we're talking about, but physiologically, why would constipation be something that leads to a UTI?
Because the rectum, if it's full, it's right behind the bladder. So it puts pressure on the bladder, and the bladder cannot empty. So you can imagine the urine that's kind of stuck on the sides. It's just stasis of the urine right there, and it's just hanging around. So by the time it comes out, it could have already become a bacteria. Plus, the bacteria that's more common that we find in UTIs is E. coli, which comes from the gut.
Okay.
So those are the biggest factors.
So when a
With
baby
baby-
has a UTI, and again, I'm going back to what we talked about in the opening, they can't tell you that it hurts. And a baby cries for a multiple of reasons, right? And so I, again, was reading up today, and there's sometimes body cues of maybe faces they make or maybe positions that the babies are getting into. Describe what some of those could be that a parent or a grandparent could kind of eyeball and say, okay, there's something going on here.
For babies, fever is a
Okay.
big one. And they're very irritable, they're very fussy, they don't want to eat. And so those are big flags that you need to look for in babies.
Okay. And I'm trying to think too. I don't remember how often when my little ones were little. I have a 26-year-old and 21-year-old, right? And there's like, well, baby checkups. And in general, can a UTI go undiagnosed and really become a problem? Again, if the parents have no idea that there's a UTI, and we're talking about little ones that cannot yet vocalize what's happening or going on. How common is that? And maybe it's not common at all, and we don't have to, spend a lot of time on that.
Well, it's pretty rare for it to go undiagnosed.
Okay.
Typically, what we tell families is for unexplained high fevers, when they see their pediatrician and they can't come up with a reason, that
Okay.
they should check the urine. And it's a very important point in the non-toilet trained child. It matters how that urine is collected. So sometimes it is very common to put a bag on the genital area and then collect the urine as the child urinates. That is by definition a contaminated specimen, and a bagged specimen is actually only valid if it's negative. If it's positive, it could be
How
skin flora.
difficult is that, though, to collect the urine? I
So
mean,
typically we have to use a catheter. That's the
oh,
best way to get a urine specimen in
yeah.
a baby
Hmm.
when you are concerned for urinary tract infection. So the threshold has to be met. We're not suggesting that all children need to be
Right. Of
catheterized.
course.
But
Yeah.
in order to really define the urinary tract infection, it matters how the sample is obtained. Many patients that come to our clinic with a history of urinary tract infection actually have never had one.
Hmm.
It's always how the sample is obtained, and sometimes those patients have contaminated samples. And then we have sometimes indiscriminate antibiotic use, and we have a lot of issues around that. So you ask a very good question. And the urinary tract infection is a diagnosis of exclusion. And when it's suspected and there's a high index of suspicion, a catheterized specimen is probably the best specimen for the non-toilet trained child, boy or
Gotcha.
girl.
Yeah, and very specific. Makes sense. Let's talk about renal colic because that was new to me before today's show. It's like I don't think I've heard of that before. So who wants to take that one on?
So we can talk about renal colic. So renal colic is a little bit of an ambiguous term.
Mm-hmm.
It is supposed to be defined as pain with the kidney. Pain with the kidney typically happens in the setting of infection. Think about someone who has a urinary tract infection that spreads to the kidney. That can cause pain or renal colic. Renal colic can also be seen in the
And
setting
might
of
this
stone.
manifest in like back pain for the child?
Usually back
Again, I'm
pain.
trying to think of cues that the parents would be looking
Children
for.
will just cry
They'll just cry.
and they'll tell you that their tummy hurts.
Okay.
And so, again, a high index of suspicion is necessary. And there's certain conditions that lend itself towards renal colic. For example, some of those conditions that we detect prenatally, like swollen kidneys. Swollen kidneys or a history of swollen kidneys and renal colic should prompt a workup or at least a call to a pediatric urologist. Sometimes stones, as they're made and passed down the urinary tract, can
See, I think
block.
of stones as something old people get, but
Children
this
get
is,
stone.
oh
We
goodness.
live in the
Yeah.
desert.
We drink water, drink water, drink
Correct.
water.
Hydration
Right.
is a really, really big factor in stones, and stones can happen in children both from causes like dehydration, but also from congenital issues as well.
Okay. And treatment of renal colic. Well, how do you treat it?
Define the problem. We have to define the problem
Okay.
first. And oftentimes the first step is an ultrasound, and that's actually a really important point for the
Oh, the
folks tuning
diagnostic.
in.
Okay, diagnostic area.
It's very common to get a CT scan,
Okay.
and that's usually done for adults. In children, we really want to limit their radiation exposure. So typically at a children's hospital, the ultrasound is the first step. It's
Okay.
non-invasive. It doesn't require radiation. And in my mind, it's the safest test and the biggest bang for your buck. A CT scan is very, very commonly done, and I would discourage its use in children for diagnosis of renal colic.
So you bring up a really, really good point. If you're looking at the visibility of each one of these scans, as a doctor who is recommending perhaps not to do a CT scan, doing an ultrasound versus a CT and the clarity of the vision, the what you would receive in a what am I looking for? The imaging. Sorry. Sometimes I lose words. How different is a sonogram versus a CT scan when it comes to imaging and the clarity of the imaging?
So it gets back to wanting the best for your child.
Right.
And in my opinion, the best care for your child is a children's hospital, where all they do is take care of children. Because if you go to a hospital that mainly takes care of adults and then sometimes takes care of children, like, for example, an emergency room, you're going to have the problems you described. The ultrasound may not have the quality of images that you need.
Gotcha.
Versus at a pediatric hospital, it will, because that's
This
what
is
we do all the
specified
time.
for little people.
Exactly.
Okay. That makes sense. I like it. Question here. We talked about what could be mistaken for a urinary tract infection. Actually, we haven't really talked about that. We talked a lot about urinary tract infections, but what might be mistaken for a urinary tract infection?
You know, Belen, I'm going to let you do this because we saw about 5 patients today with exactly this.
Oh, hello. Well, there you go. Taking it straight from work to the dinner table. Let's consider ourselves the dinner table tonight.
Well, a lot of times kids will say, "Oh, it hurts to pee," but their vagina is all irritated. It's all red. They sometimes have leakage. That sometimes we're examining them, and we show the mom, "Look, I just opened the legs, and the urine just leaked out," and so that causes irritation to the skin, which is vulvovaginitis, and it's not a UTI, but it is irritation of the vagina.
So
caused
describe what
from the-
vaginitis is, if you can define that.
So it's the irritation right around in the vagina and around the
So
vagina.
inside the vagina.
Inside, and it could be outside also.
What causes that? Just
So-
constant wetness?
So yes, constant wetness, exactly. And because the urine, especially if you're dehydrated, will irritate the skin.
Okay.
And a lot of kids, well, not so much because they're from the South. I had one little girl that her grandmother taught her that when she pees, she had to close her legs because only a lady always had her have her legs closed. But also the little kids, they don't want to fall in the toilet. So they're holding on and they're squeezing their legs. So if you learn how to pee with your legs closed, the urine never quite
Completely gets out.
Yeah, and it gets
Okay.
stuck. So that's very common. And then because you have the redness and irritation, then the urine is a contaminated specimen. And even though it might grow bacteria, it may not be a true.
So let's take this to a practically applied science. So potty training chairs and seats, right? I feel like it's the most obvious thing, but maybe it's not. But I can envision my little ones too, when you're in a public bathroom or something, literally, I remember holding them because they would literally fall right through, right? So if you have the ability to have a potty training seats, again, is this something that's even questionable? Is it even an issue? Am I just being a nut? Is a mom who's got old kids at this point?
No, not at all.
Dr. Alum, feel free to take that one.
I tell a lot of my families that these are problems of the industrialized world. It actually doesn't happen when children squat devoid
Ah,
in a hole.
Right.
And these are Western-style toilets that
feel like
cause
you're
this
peeing
problem.
in the woods.
Exactly.
Right.
And so what happens is when the children urinate, the urine goes into the vagina, which is a potential space. It gets held in there. And then when it comes out, it can be mistaken as incontinence, which it's not, or it may have a smelly or smell to it. It may have an odor to it, and the parents think it's a urinary tract infection. It's just vaginal trapping of urine. So they make devices where you can put your legs up. They make devices like smaller toilet seats, and it's just about toileting posture and to make sure the children are comfortable when they void and more relaxed, so they're not tightening their pelvic muscles when they void. The significance of this is that children who develop dysfunctional habits of voiding sometimes become adults with dysfunctional habits of voiding that can include things like bladder pain, frequent urinary tract infections. They can carry them for the rest of their lives with these problems that are pretty easily identified and addressed in childhood.
I really like the wording toileting posture.
Yeah.
Right? It so describes what you're talking about. And so from the get-go, and that's something, again, as a layperson, that's not something I think about, but describing it, that makes all the sense in the world. Let's talk a little bit about, we talked about trying to drink a lot of water, especially in the desert. So in general, that's great to do. Bladder function. So when we talked prior to us beginning this program, I was kind of giving you a list of questions that I researched and did. And he says, oh, this is a good one. So what tests are done to check bladder function? And I'm going to start there because we're talking about urinary issues in general, but we haven't really talked specifically about the bladder and what issues could be going on with the bladder. So what kind of tests do you do for that?
So to talk about the bladder requires a little bit of an understanding of there are two different kinds of urology. There's the basic pediatric urology and complex pediatric urology. So some children are born with conditions that cause the bladder to be abnormal. Spina bifida, anorectal malformations, or conditions that actually have an impact on the shape, function, size, or position of the bladder. And in order to understand if the bladder is working properly, and more importantly, if the bladder is functioning in a manner that is safe for the kidneys, we have to do bladder function tests. And those are called urodynamics.
Okay.
And we are the only gig in town in terms of El Paso where we do pediatric urodynamics. And that's done in the clinic, and it's done with the patients awake. It involves placing a catheter in the bladder with a special pressure sensor on it and a catheter in the rectum. And what you do is you measure the pressure in the rectum, which is a surrogate for the pressure of the belly. You measure the pressure in the bladder, and you subtract one for the other, which gives us the pressure of the bladder muscle. And that test is done usually with fluoroscopy, where we inject a contrast and take pictures and we look at how the bladder is functioning. And so that's the extreme bladder measurement test for patients who have conditions that are concerning for what's called neurogenic bladder.
And what would those symptoms be? And again, I'm thinking about people who might be watching this, and what would they look for in symptoms with this?
So it requires usually an underlying diagnosis,
Okay.
such as spina bifida, anal rectal malformation, bladder
Okay, so you talked about
exstrophy.
that. Okay.
And so those are the conditions. Now, there's another bladder test we do called a non-invasive urodynamics, where children void into a special commode that has a pressure sensor on it. And they have little stickers that's on their perineum where we can measure their pelvic floor muscles. And as they urinate, we try to determine if they're emptying their bladder, if they have good flow, or if while they're voiding, they're tightening their muscles when they shouldn't tighten. And that is dysfunctional voiding. And sometimes we see that in children with constipation. The symptoms are usually my 4-year-old child was toilet trained and now they're wetting themselves all day long, or they're wetting themselves at night. And we've gone through and done everything that's necessary to rule out other problems. And then we do a test to see if there's any dysfunctional component of their voiding. And that's done with the patient obviously awake, no needles, nothing invasive, just some stickers on the bottom.
Just some stickers on the bottom. So I'm just thinking cognitive behavior here, right? It's like it's training them, teaching them
Correct.
About the dysfunctional voiding and toilet posturing. So is this something, and Belen, just to bring you into the conversation here, something that you're helping teach the parents to teach the kids? And I'm just trying to think of, again, when my little ones were little, all kinds of things, because you can talk about anything with a little one and they're not embarrassed because they don't have that little key in their head yet. So when you're trying to teach parents to teach their children about posturing, about voiding correctly and not dysfunctionally, how does that training occur?
Well, when we do the Euroflow, we show them,
Okay.
this is what we're looking at. And this is what your bladder capacity should be. And this is where your son is at, or your daughter. And let's say that their capacity should be 200, but at 97, they already had urgency. So that already you're identifying a problem. And then when they flowed, you could see that the flow was intermittent, like they did not have a good flow. So that they are tightening their.
And does the child know that they're tightening?
No,
I
they
guess
don't do it.
That's where it is. I'm
No.
trying to think of cognitively how to
Exactly.
get someone who's just potty training, right?
Right.
Let's say 3-ish.
Right.
How do you teach that? Like how are you describing to the little one? What are you feeling, and can they describe it back to you? And why are they tightening? Why are they not tightening? And how do you train them? Like I'm super curious about how that would.
They're video games, actually.
There we go. This is what I'm talking about. I'm like, how does this work into the? Okay, so talk about the video games.
So the pressure sensors, the stickers on the bottom, will register, and they can be programmed into a video game to teach the kids how to tighten, how to relax. And usually we don't do this on 3-year-olds. You want to have the child a little bit older before we do this. It's called biofeedback.
Okay.
And it's basically training them how to void in a manner that's more consistent with getting urine out.
So throw me an age, más y menos.
For biofeedback, the youngest I would reasonably expect success would be 5.
Okay.
But even that's pushing it. We typically do around 5 or 6.
Okay. And that's truly when they can be descriptive as well, right? To kind of talk about what's happening, what's going on. We can get all kinds of stuff here. What I really want to do is talk about non-complex and complex. So we talked again prior to the show that prior to the service line, what was happening in El Paso were surgeries and just issues that were being treated that were non-complex. But now there are complex issues being treated. Can you describe a little bit more of what that means?
So the most invasive thing that we do is urinary tract reconstruction.
Okay.
And so these are patients who are born with bladders that leak, meaning they have no sphincter. And so we have to create a mechanism in which the bladder can hold without them being in
without a
diapers.
sphincter.
Correct.
Okay.
So it's not great to be 7 years old and still in diapers when your classmates are not. So we provide the children with a sense of normalcy. And it's a big operation. And so sometimes it involves closing the bladder neck. Sometimes it involves reconstructing it such that it doesn't leak. We make bladders bigger using pieces of intestine. We create channels where instead of catheterizing through their urethra, meaning their penis or their urethra in a female, we catheterize through a special opening on the abdomen. And some of the patients have fecal incontinence, and just doing urologic reconstruction and then leaving a child soiling themselves in diapers is not the okay thing to do. And so we do things like create little openings where they can give themselves enemas while sitting on their toilet from a small little opening in their belly.
So they can do this themselves.
They can do
so the
that.
way
That's
that
the
you're
goal.
reconstructing all those areas that they're, again, it's a whole teaching moment.
Correct.
And in the past, they'd have to go to other cities, et
Correct.
cetera. So this is relatively new in El Paso. And I'd love for you to kind of take that forward.
So since I started in El Paso back in March, we have now done 4 of those cases.
Okay.
The patients are all doing very well. 2 of those patients are El Pasoans that actually were on the surgical schedule at other hospitals in different cities. But once they found out they had the opportunity to stay in El Paso, they stayed in El Paso. We actually did the final test on one of the patients today, and I'm delighted to say that she is dry and clean, and it's the first time in her life.
Oh, and how old is she?
She's 7.
She's 7. That seems so old.
And then
Yeah,
2 other
right.
patients came actually from out of town. One patient
Okay.
came from New Jersey, a patient that I had seen when I was in New York. Another patient came from South Carolina for these operations. These are typically long operations, sometimes up to 14, 15 hours.
Oh my. Okay.
And they're pretty labor intense and resource intense operations. But the most important thing is for the community of El Paso, we now have the ability to take care of the patients here.
So I'm thinking if this is a 14-hour Mas Menos type, how much planning and how much pre-operative do you have to do? Or is it all literally taken care of in the operating room that day? Like, I was going to say, because reconstructing, there's a lot of pre-planning for that. Maybe describe, not so much in detail because of the time, but describe what it is that you have to pre-plan. These are reconstructive surgeries.
Correct.
That, to me, it seems incredibly complex.
It is very complex, and it starts off with obviously defining the problem, doing the urodynamic studies, and medical management. That is the beginning of what every pediatric urologist does. Sometimes we try and medically manage the bladder with medications and catheterization to determine if we can make the bladder grow, if the patient can be dry, if the kidneys can be safe. We do all those things for a period of months to sometimes years before we do the reconstruction. I don't do these reconstructions until the children are anywhere between 4 and 6 years of age.
Okay.
We usually wait. The reason we pick that is I like my kids to be clean and dry by 2nd grade. And a lot of people will not want to talk about this. Sometimes the patients are in wheelchairs and they are in diapers, and some folks have normalized that. But I don't think that being clean and dry is something elective. I think every child deserves that. And sometimes there's a safety issue as well. Sometimes people are incontinent because of some bad bladder stuff. And we do these reconstructions and identify it medically to help those children so they can lead normal lives and productive lives.
And how does that conversation start? Like, and I love that you're using the word, we don't want to normalize that, that if it becomes normalized, now you're in a family situation where, oh, that's just the way it is. How, as a doctor who sees this going on, who's the one that starts that conversation? Is it usually the parents that start the conversation? Is it the child themselves, perhaps? Is it the doctor just saying, hey, these are some options? In general, how does that usually come about?
It really depends on the people around the child.
Okay.
There are sometimes socioeconomic barriers. Sometimes there's a reticence to really want to address things. Sometimes there's a reticence to understand what the family is going through. So unfortunately, sometimes families with the least means have children with the most needs.
Right.
And it really requires kind of a fundamental rethinking of how to help families. We have to first define what their barriers are, whether it's education, whether it's being able to get to the clinic, and explain to them that here are your options. This is possible for your child. And so it really depends on how we get that message out there. But what I love are the disruptive technologies like Facebook and the family support groups, because I'm a big fan of calling physicians to task.
Right. And that's kind of where the question's coming from,
Oh,
right?
no.
It's like, how does that conversation start? Who brings it up? Who unnormalizes certain things, if that's even a proper way of describing it. So I like the way you talked about that. I would love to go to this great acronym, the CAKUT, Congenital Anomalies of the Kidney, Urinary Tract, Ureter, Bladder, and Urethra. That's a lot to say, right? But the key word here is congenital.
Correct.
And so let's just open the conversation about this.
So
Identifying prior to birth, et cetera, et cetera.
Exactly. The best way to think about this is, excuse me, for children with kidney disease in the United States, the cause of renal failure and kidney disease in children in the United States, 50% of the time is related to a CACet condition. It's very different than an adult. An adult who has kidney disease and kidney failure is usually because of some anomaly, for example, high blood pressure or diabetes. In children, the script is flipped. It's CACet. Now, not every child with CACet will develop kidney disease.
Okay.
But it is important to understand and diagnose CACet so that you can you can stop preventable renal harm. And so CACet spectrum anomalies include things like reflux, urine that goes backwards up into the kidneys, or swelling of the kidneys. And those are examples of things that sometimes we detect prenatally, mostly the swelling. And the important aspect of the acronym is that it really helps people understand the diagnosis so there can be a lifelong follow-up plan. And again, kind of putting forth the importance of the medical management and follow-up of the patients.
So treatment. When you say lifelong following, what does that mean in treatment going forward? Like when you say following, describe the following from, again, this is birth, and now someone who's 25 years old, so full-on adult.
Okay.
How do you follow this
So
CACet?
typically you follow from a kidney standpoint with ultrasounds and blood draws and measurement of kidney function. And so let's take the extreme example. There used to be something called Diedel's crisis, where a young adult, 18-year-old, would go to college and discover two things, not necessarily in this order, but coffee and beer. And they would have an underlying obstruction of their kidney and would make a large amount of urine because of coffee and beer,
Right.
and present to the emergency room in pain. And lo and behold, they would have swelling of their kidney. Now,
And they've never noticed this before. It's never been an issue before, but now they're in college and boom, it's an issue.
And so we now have kind of eliminated that because of prenatal testing. And so those are patients who are followed, sometimes repaired or watched, depending on the kind of swelling of the kidney. And they may have a plan for the future that if this happens, then we need to do this.
Okay.
And we try and explain to our patients as they become young adults to be able to advocate for themselves and to say these are the things that need to be followed.
See, and I'm thinking to myself too, again, I have a 21-year-old boy, and would he even bring this up to me? Would he bring it up to a doctor? Just all of a sudden, it's like, man, I've got a lot of urine in me, and I guess. So when and how do you find young ones who are college age bringing this up? Or is it just something that, and they're not going to go to the doctor. I mean, how often do they don't go to doctors yearly until you start screening stuff, right? I mean, how would they know that they have an issue is, I guess, the question. Is there pain involved?
Well, that gets back to the renal colic question. And so, so typically renal colic, when it's severe, we'll bring someone to the emergency room, and the diagnostic test will then make the evaluation. The Diedel's crisis phenomenon is really a phenomenon of the 1970s and 1980s. It's really something that doesn't happen. It's very rare to have a de novo presentation of a bad problem.
Okay.
But, with any sort of young adult, typically when there's a partner involved,
Right.
girlfriend, boyfriend, or otherwise, they tend to toe the line and do as they're told and come to the doctor if there's a
Tell you
problem.
what, partners are so important when it comes to stuff in so many different medical issues. It's like, hey, you're having an issue, go check it out. We are at about the 10-minute mark of the show ending. So what I'd like to do, Belen, she's like, what? Is there anything that we have not yet There's so much to cover here. I mean, we can do like hours and hours on this program. Is there anything that for tonight we haven't covered yet, or something that maybe we touched base on that you'd like to cover some more before we start closing up. It goes by so fast.
I know it does.
It does. But I'd love to make sure that what you all came here to do is something you came here to do. Is there anything that we haven't discussed yet that you'd like to bring
Well,
up?
we haven't talked about testicles.
Okay, we haven't. You're right.
So as they're
Let's talk about testicles. This is a PBS program. This is the place you can do it, right?
Right.
So yeah, let's do.
So a lot of premature babies, their testicles won't drop.
Mm-hmm.
So the pediatricians are pretty good about looking for testicles from the time that they're born. But they do get referred to us because sometimes the babies are very chunky and you can't quite find the testicle because they're kind of fat. The little fat pad obscures the exam of the testicle. So that's important to know because
So
they
I'm going to
haven't.
interject a question here
Yes,
because
go
I
ahead.
don't know this question. When are they supposed to drop? Is
If
this
they're
prior
not
to
down,
birth?
if they're not down by 3 months, they're not going to come down.
If they're not down by 3 months, they're not going to come down. Look at the stuff I'm learning. Okay. So now what? They're not
So-
down and somebody's 4 or 5 months old. Now what?
So now they need surgery.
Okay.
But they won't get surgery until they're 6 months. But it still has to already be scheduled and be planned.
Okay. I'm going to, again, the brand new mama who doesn't even know to look for this. And this is where I guess the checkups, the well baby checkups come in, right? Which is super duper important.
Yes.
How would a mother who maybe didn't go to the doctor and do checkups, are there any physiological medical issues that are happening as far as urinating or anything that a mom would know that the testicles haven't dropped? I don't know how to ask that question. I
Because
don't
a
know if
lot
I'm
of
asking it
times the
right.
scrotum looks normal
Right.
and they wouldn't know if they're not feeling the testicles.
Okay.
So they may not know.
They may not know. So
They
what
may-
happens then that now a child is 7, 8, 9 months old, testicles still haven't dropped, nobody knows about it.
Well, hopefully when they go for their well baby check, the pediatrician, because they're very good,
Mm-hmm.
they will notice.
So
And
this
then-
may
and
be
they-
a show to advocate. Go get your well baby checked.
Yes.
Yes.
For
Okay.
sure. And they
Okay.
will refer them to us and we take it from there.
Okay.
But as they get older, they can have testicular pain just from constipation because that poop is so predominant in that area that it's pushing on the testicle.
Okay.
So
Have
They
there
might-
been any, again, just think of a case study where, a child, I don't even know what age, where the testicles have not yet dropped, the child parents don't know, and you're into 2 or 3 or 4 years of life. Has that happened?
Yes.
And if it has happened, what do you do now? And what are the issues that are occurring with the child?
Well, you can still do surgery.
Okay.
Sometimes the child will be 7 and they just, for a variety of reasons, weren't diagnosed. We like to do surgery early. The early surgery tends to preserve fertility and prevent problems in the future, although that data is not 100% great data. But we can do orchidopexies in patients that are 7. The most extreme, sometimes you'll see patients that come in at 18, 19.
Oh my.
And if the testicles aren't down and if they're not able to be palpated, sometimes we remove those testicles because at that point, there may be a slight increased risk of malignancy.
So I'm embarrassed to ask this because I'm trying to visualize this. So the testicles are where then? If they're not dropped, they're literally at the level we were talking about constipation. So they're still kind of hanging out in the cavity. And when somebody's 18, 19 and they have not noticed this whole time, and I guess again, if there's no locker room talk, if there's
Right.
nobody to compare yourself to, which again, that goes back to the very beginning opening statement, right? It's like disruptors. Like, how would you know if you don't know? How do you know what you don't know in a situation like this?
Well, With the internet now, a
the
lot of
internet,
people
that's a good point. With the internet
do know
now.
things.
Right,
It- sometimes it just has to do with medical literacy and access to care. I mean, it's a very difficult thing to wrap your head around, but sometimes people are born into circumstances that they don't
Yeah.
have the same opportunities that the rest of the patients have.
right.
Either way, it's not something to be scared of or ashamed of. These are all conditions that can be fixed really at any point. I didn't mean to talk about removing testicles. I just gave that as an example.
Right. And I'm just thinking too, just in general, the embarrassment that circle around the word genitals, that take that away and let's really discuss these things.
Absolutely.
On that note, now it's your turn. Is there something that we haven't touched base on yet that you'd like to bring up before we start wrapping up?
Specifically, I just really want to get the message across that these are really not part of polite conversation, but it should be. Pediatric urology conditions are something people should feel confident and comfortable talking about. Normalizing peeing and pooping with your child is really important. Normalizing anatomy, normalizing sexual function as the time goes on, and normalizing the ability to ask questions when the child perceives something is incorrect or something is wrong, I think is the most important thing to get across. We're plumbers and we take care of things that people don't really talk about at cocktail parties, but these are really important aspects of life and they can have significant psychosocial impacts as time goes on.
I'm in full agreement. So Diego knows this because it was part of our conversation we had at lunch the other day when we were talking about our yearly gathering. But this program started 26 years ago. I was at the American Cancer Society and nobody wanted, that's why I said about testicles, right? Nobody wanted to talk about testicular cancer. And that is kind of and I know it's out of the world of pediatrics, but it's kind of a younger man's issue. And so I approached PBS at that time, and it was one of those things like, you can't say testicles out loud. And like men would literally start shifting in their chairs. And so I'm so glad that here we are 26 years later, and we're talking about this openly. And again, with social media, that these are just things that you can access. And I think if kids have curiosity now, blessings and curses of phones, I get it. But some of the blessings are that you kind of can go research. Sometimes it's not good research, but in general, it's at least out there to be found.
And there are a whole host of books about, like, everybody poops. And
right.
One of my patients' mothers actually wrote a book about urinary tract reconstruction. Little bunny has bladder surgery.
Right. I love that this is a thing. I want to say thank you again, Dr. Alam, again, pediatric urologist at the El Paso Children's Hospital, and Belen Terrazas, nurse practitioner, testicular. That's also one of those that doesn't come out easily. If you only caught part of this program or want to see this in whole, once again, you can do it in 3 different places. You can go to pbselpaso.org and you can find it there. Again, just look up the word the El Paso Physician. EPCMS, which is the website for the El Paso County Medical Society. That's epcms.com. And then good old-fashioned YouTube, youtube.com. And then in there you can write and use the word the. So the El Paso Physician, the El Paso Physician. And usually that pops up. And the great thing about going to those platforms is that, yes, we're talking about pediatric urology, but you can find all the programs that the El Paso Physician, the El Paso County Medical Society has been doing for years, and you'll have a backlog on all of that. And that's good for you guys to go back to and look too. If you feel like we discussed something today that one of your patients can benefit from, they can go back and kind of listen to this conversation. So I thank you guys very much for being here. And again, thank you to the El Paso Children's Hospital and the El Paso County Medical Society for, again, bringing the show to you each and every month. I'm Catherine Berg, and this has been the El Paso Physician.